Abbiamo qua Ilaria Dorigatti, che penso che molti di voi abbiano sentito nominare. Lei è, visto che la conosco bene, ha fatto sia la laurea che il dottorato con me all'Università di Trento, per cui diciamo la conosco da abbastanza tempo. Dopo il dottorato è andata a lavorare all'Imperial College a Londra, in uno dei gruppi probabilmente più importanti al mondo di modellistica epidemiologica, e si è lavorato su molti problemi e molti tipi di infezione. Ha lavorato inizialmente sull'influenza pandemica H1N1, ha lavorato su Ebola, ha lavorato su Zika, ha lavorato su Dengue, su moltissime delle malattie, passando anche proprio un po' sul versante medico, per cui si è occupata anche di modellizzazione delle vaccinazioni, qual è l'effetto delle vaccinazioni, eccetera. E come tanti negli ultimi anni si è occupata molto dell'epidemia di SARS-CoV-2, naturalmente, direi dall'inizio, già da gennaio 2020 ha cominciato a lavorare su questo tema con i primi dati disponibili dalla Cina, e ha continuato, direi, per molto il tempo, e oggi parlerà appunto proprio delle questioni della modellizzazione, per ora della fase iniziale dell'epidemia. Non ci dirà che cosa succede il mese prossimo, penso che Ilaria non ce lo possa dire, invece ci parlerà soprattutto della modellizzazione della prima fase. Prego Ilaria.
Beh, grazie Andrea per la presentazione proprio generosa. Prova a condividere lo schermo. Riuscite a vedere?
Sì, vediamo. C'era un po' di ritorno, ma prova a parlare adesso e vediamo.
Okay, I will switch to English then, if that's fine, right? So thank you so much for the kind invitation, and thank you for the introduction, Andrea. That was very, very generous of you. Let me see. So I'll start with acknowledgements, because this is truly what I will talk to you, about today, today is really like a team effort. And I'd like to really thank all the people who have worked very intensely together with me throughout the pandemic. This is the colleagues at Imperial College and the Imperial College COVID-19 response team, but also all the people in Padova. You will see that this work has been done very much in collaboration with them. I have helped essentially them analyze and model the data that they have been producing in Vo. I will tell you about this little village where everything started at the beginning of 2020, like the pandemic started. And I'd also like to thank the funders, and in particular Wellcome Trust and the Royal Society. They are funding my fellowship, but also the MRC Community Jamil and the European Horizon 2020 and the Regione Veneto, who funded the study that you will see in the next few slides. So today I will tell you mainly about 4 studies, and I will focus on the modeling part as much as possible of these studies. And these 3 of them have been published. The 4th one is currently under review, and we are nearly ready to submit it. So it will be great to receive your feedback on the last one as well, which is still in progress. So as you all know better than me, Italy was the first European country to be really affected by COVID-19 outside of China in 2020. The first death due to COVID-19 was recorded on the 21st of February 2020, and that was recorded in Vo. Vo is a small municipality of around 3,000 residents in the province of Padova. And the local government decided, that was one of the first decisions that were done at the European level outside of China, that for 2 weeks they were going to lock down in an attempt to try and control this new disease, which didn't even have a name of SARS-CoV-2 at the time, but it was like a new coronavirus. And so this new lockdown was implemented between the 24th of February for 2 weeks. And the University of Padova decided to go there in this village and do 2 sequential molecular swab surveys. So the first one lasted just over a week. We started on the day where the first death was found. Essentially, it was a matter of going in the village, going house by house and swabbing people with molecular tests. There weren't antigenic tests available at the time, something that we used to use maybe now, but at the time it was only about molecular swabbing. And along with the results of these molecular swabs, we collected a few additional information on the just to understand a bit more about the epidemiology of this new virus. So we collected demographic information on the health conditions and medical history, the contacts, the symptoms, the dates of symptom onset, and so on and so forth. And at the end of the lockdown, around the end of the lockdown, so on the 7th and 8th of March, we went back in the same population and we repeated this swab survey. So what did we find? So just to contextualize a bit, these results. So that was a time where we knew that there was an outbreak of this new disease in Lombardy, which was already severely affected, and the hospitals were already kind of maybe in an emergency situations. But apart from that, there weren't data, and there wasn't quite any clear indication about this virus having spread, in the rest of Italy. And so these surveys kind of opened our eyes a little in terms of really understanding that this virus had been spreading silently in the population. Because in the first survey, so around the day where the first death was found, we found a prevalence of 2.6%. Overall, it was we found 73 positive cases at the end of February. This number of cases went down very quickly after the lockdown and mass testing was implemented, because at the second survey, this prevalence went down to 1.2%. In absolute terms, that meant that we had 29 positive cases in the second survey, but it's worth noting that most of these 29 cases were actually cases that were positive at the first survey. So between the first and the second, we only had 8 new cases that were detected. And it's also worth noting that we managed really to swab the majority of the population, like more than 80 or 86% of the population. So it was quite extensive, the amount of testing that we did. One of the strengths of these surveys were that we asked about symptoms at the time of testing, but also we asked about symptom onset after testing, so that we could follow the people, up to 3 weeks after they were tested. And we had an idea of whether, people who were not showing symptoms at the time of test were perhaps developing symptoms afterwards. And so at that time, just to contextualize again, there weren't any estimates around what was the frequency of symptom onset. And what we found actually, that if we look across the 2 surveys, around 40% of the people positive were completely asymptomatic. That means not showing symptoms at the time of test and not developing symptoms in the 3 weeks after either, which was perhaps one of the key findings of this study. One of the first epidemiological analyses that we did was trying to reconstruct the transmission chains. And this was possible because as we were doing the swab testing, we also asked people about contacts, whether, they were willing to tell us about kind of contacts that they had the week prior with the people in their community. And so this allowed us to reconstruct the transmission chains. And once that you reconstruct the transmission chains, one of the first epidemiological quantities that we wanted to reconstruct was a serial interval. Serial interval is the time from onset of symptom in the infector to onset of symptom in the infectee. And we found estimates of around 7.2 days overall. These were very much in line with estimates that were coming out from Lombardy. And we found a reproduction number of around 2.4 in the pre-lockdown phase, which was clearly crashed after the lockdown, because it was really effective at suppressing this epidemic. One of the key questions that we were asked, and we asked ourselves, given that we found a large proportion of infections that were asymptomatic, was whether we could see any difference in terms of viral load between symptomatic and asymptomatic infections. So viral load can be seen as a measure of the infectiousness. It's how much virus you have on the swabs, essentially. And interestingly, we found that actually there wasn't any significant difference in the viral load between symptomatic and asymptomatic infections, which really highlighted how potentially these asymptomatic infections could play a role in transmission. And again, there were huge uncertainties around this at the very beginning. When we looked at the trends, if you want, of the viral load among the people with symptom onset. So here we plotted the viral load against the day of symptom onset. Bear in mind that we only had a single, or at most two sequential viral loads for people, and these are the viral loads that are linked with a line. But the trend that we could see, it was that the viral load tended to be higher around the day of symptom onset and tended to decrease in time. So from a public health perspective, that clearly meant that there was huge potential of transmission occurring before the day of symptom onset, which again was quite of a challenging finding in terms of controlling this disease, because people were clearly potentially able to transmit before they were aware that they had been infected because they were showing symptoms. Numbers are small, but we found evidence that infection could occur from asymptomatic infections. So 2 out of the 8 new infections between the first and the second survey were living with people who were completely asymptomatic. We did some modeling, of course, and one of the key questions we tried to answer were whether we could assess how much intervention, we could assess how effective were interventions, but also we were interested to see whether we could reconstruct the data that we had available. And the data that we had available were quite restricted in a way, because we had prevalence estimates at 2 time points. That's a point that you see on the graph in the right, and stratified by the symptoms, by the symptoms. So prevalence between pre-symptomatic, symptomatic, and asymptomatic infections. And we were interested to check and to test whether the life history of these different type of infections was, kind of similar and could be reproduced with a transmission model. And so we used one of the very simple, modeling approaches that we all use and we all know about, these compartmental models. And we built on top of what is the first and the simplest model that we know about, which is the SIR model. And we really modified this SIR model to account for the information that we retrieved from this study. So we knew that there was a pre-symptomatic period, because we could see that we found people who were testing positive before showing symptoms. And this really led us to include this TP class, which is people testing positive before showing symptoms. Then these people were split into people who were asymptomatic down the bottom, or people who were symptomatic up the top. Here I am presenting the final version of the model, but essentially to capture the dynamics, we had to include this extra class. We called it TPS and TPA, which is people testing positive but not being infectious. So here, to reproduce the dynamics, we had to assume that infectiousness lasted for some time, but then people were testing positive beyond the infectious period. And this is very much in line with what we know now about PCR, molecular testing being so sensitive that people test positive well after the infectious period. And so this is kind of one interesting fact, if you want, that we found out from modeling at the population level the very beginning, where we didn't know really much about duration of infectiousness and sensitivity of PCR versus antigenic tests. And effectively at the end, everyone would test negative and recover. So that would be equivalent to the R compartment at the end. We used the Bayesian framework to calibrate this model to the data that we had, like 2 data points stratified. And we did a good job in terms of reconstructing what were the dynamics. We estimated that effectively R0 was reduced by 82 to 99%. That's a cumulative effect, if you want, of mass testing, quarantine, and lockdown all together. We can't differentiate these. And of course, then we were interested in running a counterfactual analysis. So the question was, what would have happened if mass testing and lockdown were not implemented? So that's a matter of really running the model without risk reduction in the reproduction number that we had estimated. And we found that without a lockdown, we would have expected around 86% of the population to be infected, as opposed to around 5% with the interventions implemented. We follow the same population, like the VO population, with a couple of serological surveys. First was done in May, so a few months after the epidemic, and then again in November, so at the end of the year. One of the strengths of these serological surveys that we conducted were that we didn't just use one of the immunological assays that were commercially available at the time. We used 3 of them and a neutralization assay. And there were, one of the reasons was because these assay tests for different antigens. So the Abbott and the Roche test for the N antigen, the Diasorin looks for the S antigen. But also we were really interested in kind of comparing what the impact of using different tests would be, especially because worldwide different places were using different tests. And so, we were interested to see whether the use of the test was really affecting the results, essentially. And because we used different tests, we had issues around interpreting the results. Because effectively, if you test the same blood samples with 3 different tests, you may find that the tests give you discordant results. So for instance, here highlighted in red is, the number of tests in May, for instance, that resulted negative for the Abbott and the Roche, but positive for the Diasorin. So you see that there is this issue of having discordant results when we use multiple tests on the same sample. And clearly, when we have discordant results at the individual level, then we have discordant estimates at the population level as well. So one of the things that we can do is look at what we call the raw seropositivity, the raw estimate of seroprevalence is just seropositivity. You just take number of positive divided by number of testings, but using the different assays. And if you do that, you see that you get slightly discordant results, and that's the blue results, and they are circled in red. When you try to adjust for the sensitivity and specificity of the different assays, these estimates actually go farther apart rather than closer together. So when you try and adjust, the seroprevalence estimates just by looking at the different assays independently, actually you get estimates that are less consistent than before, even if they are adjusted. So they supposedly they had to be better. So then to try and reconstruct what the true seroprevalence was, we built a likelihood-based approach where we try to combine together the information that we have on the different assays and on the on the combinations of the results that we observe in the population. So essentially, it was really writing down the likelihood. So what's the probability of observing the data given our model, taking into account for what we call the validation experiment results. Those are the experiments that were done to estimate the sensitivity and the specificity of each assay in-house. So essentially to validate, to estimate the specificity, they took some samples from the pre-pandemic period and they tested them. And they assessed the specificity of the different assays. And to test the sensitivity, they took the samples from PCR confirmed patients, they tested them, and this gave estimates of the sensitivity. And here, instead of taking sensitivity and specificity as the punctual, like the mean estimate as positive divided by tested, we accounting for the distribution. It's a binomial distribution. What's the positivity of having P positive out of T tested? And we combine that with the probability of having results combinations that we observe. So this is very much an exercise of writing down conditional probabilities. And what we were interested in is theta here. What we call theta is the prevalence, the probability of being infected. That's a prevalence that we want to estimate essentially. And so we calibrated this model to the data that we had. So both the validation experiment data and the result combinations that I've shown you in the previous slide. And what we got is the estimate that you see in yellow here. So on average, we found a prevalence of seroprevalence of 3.5% with an uncertainty between 2.8 and 4.3%. And this is really taking into account all of the results obtained with the different assays. In November 2020, we only tested the positive subjects. So the subjects who were tested positive in May or who we knew were positive in February and March. And what we could see is that actually depending on the assay that we were using, we would see a slower or faster decay. So when using the Abbott, only 36% of the samples of the subjects positive in May were still positive in November. With the Diasorin and the Roche, the positivity rates were much higher. We also found evidence of re-exposure. So these are the trajectories that you see in red. Those are individual trajectories. So those are people who kind of showed an antibody titer more than doubling between May and November. So, they must have been re-exposed to have that kind of increase in antibody levels. 56% of these people reported contact with PCR positive people to support the idea that potentially they were reinfections. And the good thing was that actually these subjects had either very mild or no symptoms at all. So to suggest that, potentially re-exposures were less symptomatic and less severe than the first infections. We did some within household transmission modeling. So in this case, we had information on the serostatus of all the subjects, all the within household subjects of 1,118 households. And so this is really information that we gathered from these mass serological surveys conducted within BO. And the objective here was to try and reconstruct the final size that we observed by household size. So we applied a method that was developed by Christoph Fraser in the context of flu, of the 2009 flu pandemic. The objective here was to try and reconstruct the probability that a household of size N with S0 initial susceptibles had M infections. So that's the final size distribution of the households of different sizes. And just to give you an example of what a chain binomial model is, a chain binomial is essentially a simplification of this model, which was a bit more general, but fundamentally the concept is the same. So with this model, all we wanted to do is write down probabilistically what was the probability of having a total number of infections, given the size of the household. So if you look at the example on the right, so assume that we have a household of size 3 and assume that we know that we have one initial infection. Well, then what is the probability that at the end, we have 1 infection, 2 infections, or 3 infections? Well, if we denote by P the probability of infection, and Q is what we call the escape probability, is 1 minus P, the probability of not being infected. Well, then you have a single infection overall if this single infection, initial infection, doesn't infect anyone. So that probability is Q squared. You have 2, a final size of 2, if this single infected individual who is introduced in the household infects 1 single person. And so that has probability 2 times P times Q, and then times Q. Or, and you can work out essentially the probability of having a final size of 3. So this was just to give an idea of the kind of exercise that we were doing here. One of the things that we wanted to do some, hypothesis testing within this exercise. And the hypothesis testing exercise that we did was testing whether we would see evidence of overdispersion in the number of secondary cases, and all the model variants where we assumed overdispersions were denoted with letter V. We wanted to test whether there was household size dependency in transmission. So for instance, whether, bigger houses were more or less affected by COVID as opposed to smaller households. We wanted to test whether there was any evidence from this data about proportions, about people potentially seroreverting. That means infected people testing negative by serology after some time because of antibody waning. And whether we wanted to test whether there were effectively some people who managed to isolate completely and not really being affected by the transmission. And those are, yes, and each of these hypotheses were denoted by different letters. And interestingly, what you see, so we evaluated the goodness of fit using the DIC, it's a deviance information criterion. Lower DIC is a better model. And what you can see is that actually all of the better models had one thing in common, which was they are all models which have the letter V included. So these are models that assume overdispersion in the number of secondary cases. So the preferred models really needed to assume this overdispersion in the Austrian distribution. And in quantitative terms, that means that we could really attribute 80% of the transmission to 20% of infections. In other words, that means that, when we estimate the R0 of COVID-19, well, R0 is really an average in the population, but the truth is that most of the people will go on and infect no one, and a few people will really infect the majority of the people. And this is the amount of overdispersion in the Austrian distribution that we estimated. We also looked at the impact of contact tracing in VO, and we were able to do this. Here I am referring to contact tracing as conducted by the local authorities. So that's an independent contact tracing that was conducted during the pandemic, and had nothing to do with the kind of questioning and information that we gathered when we were swabbing people. The good thing is that we could really merge together this information on contact tracing, independent contact tracing, with the results of the mass testing, which revealed the status, the infection status of the people who were traced and, the people who were traced. So we found that 44% of the traced contacts were positive. We modified our model to account for contact tracing, which was really modeled in a very simplistic way. But if you wanted, it was like a way of saying, well, if you are contact traced and if you are found to be a contact, well, then you would quarantine and you would not contribute to infection of the population. And what we found, we did a counterfactual scenario, because the key question was then, what is the effect of contact tracing? Can we tease apart what the effect of contact tracing was independently of mass testing? And here we calibrated the model to this extended model to the data. And if we run this counterfactual scenario where we only leave the effect of contact tracing and we remove the effect of mass testing, well, you see in the bottom that actually contact tracing would have had a very limited effect on controlling the epidemic. And, just to explain a bit more effectively, the relative benefit of contact tracing added to mass testing was kind of relative, like the big effect was really, the big controlling effect was achieved through mass testing. And if we wanted to achieve similar, efficacy just using contact tracing, well, we would have had to scale the efforts up by at least 4 times, which, just considering how many efforts and resources were put in place at the beginning of the pandemic, well, it's hard to believe how much this could have been increased. So this really showed the limitations of contact tracing, which really relies on memory of the people and their willingness to tell you about, contacts, and with a delay, especially because all of this information is acquired with a delay. In June 2021, we did another survey, again, among the positive people. This time we managed to enroll 76 subjects. So you see our cohort is shrinking more and more. I think this is the last survey that we've done, and we can go further. But that was useful because so the last survey that I told you about was November, and in December the vaccination campaign started in Italy. So in June 2021, we could look at the effect of vaccination on antibody titers, and antibody levels and neutralizing ability. And so this was the reason for wanting to do this serological survey. And effectively, we found what you would hope that vaccination does. Here we look at only diazorin, which looks for the spike, for antibodies against the spike, because we know that vaccines really induce antibodies against the spike and neutralization. And as you can see, among vaccinated people, the antibody levels and the neutralizing levels, are boosted, and they shoot up after vaccination, which is what we would expect. We also looked at, among the vaccinated people, we asked the question, well, are antibodies higher among the people who were previously infected or among the people who were initially naive and then vaccinated? Well, the answer is hybrid immunity, which is people infected and then vaccinated, actually have higher antibody levels. And you can see, in the left-hand side panel, green points tend to be higher than the points in red and the points in yellow. The difference between the red and yellow is, well, red is naive people who were living in VO, yellow is naive people who were working in the hospital where we ran the analysis. So it's naive healthcare workers. It was just another control. We also looked at the antibody levels between vaccinated and unvaccinated people. And here you can see that 2 doses actually elicit higher immunity than vaccination in previously infected people. Right, and then at the end, and this was something that we added during the review, but it was actually a very useful thing, was looking at the neutralizing ability of our serum bank that we had collected against the Delta variant, which is B1617, and Omicron, which is BA1. And the take-home message here is that we observed, both among people with 1 dose and with 2 doses, that actually the neutralizing ability went down 4-fold for the Delta variant and another 4-fold for the Omicron variant. So effectively, this was to say that, yeah, neutralizing ability, kind of the virus had changed, and the neutralizing ability of both vaccinated people really was reduced against the Omicron variant. Unvaccinated people had no neutralizing ability whatsoever, no surprise about that. And this is the last work that I will tell you about. This is the one that is currently under review. And so here we are still in Veneto, but we are not in both specifically. So here we take a bit of a bigger look and bigger view. And here we wanted to look at the effect of the testing strategy that was adopted in Veneto. And yeah, so essentially in Veneto was the first region to adopt an antigen testing strategy at scale. So they introduced antigen testing earlier than the rest of Italy, and they used it much more than the rest of Italy. So what you see on the right here is a proportion of patients receiving an antigen diagnostic test. And we really kind of reconstructed this from the publicly available data on the GitHub page of the Protezione Civile. At the time, so here we are talking about September, October, November 2020, there was an hospital-based surveillance put in place, whereby they really tested a number of subjects. Here we are talking about 1,387 subjects, both with antigen testing, an antigen test, and a molecular test. And that was run to check the validity of using antigen testing. And that was an hospital-based survey. And what they found was that, well, as you would expect, majority of these, were giving a concordant result. So they were either positive, both positive to molecular antigen or negative to molecular antigen testing. A small number of these subjects were giving a discordant result. And specifically, there were 19 people who were giving a positive result to a molecular, to a PCR test, but a negative result to an antigen test. And so they sequenced these viruses, which were discordant, and they found that these viruses were carrying mutations to the N antigen. This is why these people were testing negative to the antigen test, and they were essentially false negative because they were actually infected. There was virus inside. It was just that it wasn't testing positive to the antigen tests that were used. And if we look at the prevalence of this variant that was found in Veneto and in the rest of Italy, well, you see, and you see it at the bottom of the square, that this variant was actually prevalent, much more prevalent in Veneto than in the rest of Italy. So there was a prevalence in GSAID of 20% at the peak as opposed to 20% in the rest of Italy. So this really raised the question of whether the use of antigen tests limited the ability to detect this variant, and therefore, in a way, promoted or advantaged its transmission within the population. Here we use the data fusion approach. That means we try to combine together estimates from, epidemiological data, and these are data on the total number of positive cases reported in time, with data from the GSAID database. This is data on the sequence data deposited. So how many of these sequence variants are of this type, were carrying this mutation that was escaping the antigen tests. So we'll build an SEIR type of model. So you will recognize the structure is very similar to the structure that I told you before. So it's an SE, IP is pre-symptomatic infection, then you have asymptomatic, symptomatic people, and we assume that people also get reported and quarantined, and then they recover. This is, even if you don't see multiple strains, well, this is a multi-strain model because we accounted for the variant that was escaping the antigen tests. Well, then we included in this work the main concordant variant that was circulating simultaneously at the time. We grouped all the other variants which were prevalent at very limited and at the minority of the prevalence all together. And also we accounted for the alpha variant which emerged at the end of the study period, which is in January 2021. We assume that people are infectious if they are pre-symptomatic, asymptomatic, and symptomatic. And well, the take-home message here is that really we let this probability of detection be driven by the amount of antigen testing that was done in the population. We calibrate this model again using a Bayesian framework to the data. And essentially here, what we did was fitting this model simultaneously to Veneto and Italy. And essentially we anchored the R0 of the different variants to be the same. We assumed the same reporting rates. So the only difference was really due to the proportion, to the amount of antigen testing that was used. And effectively here, what you see is that the probability of case detection was lower in Veneto against this M variant, which is the variant that is escaping the antigen testing, because of the use of antigen testing that was done. Just to reinforce this concept, we did a bit of counterfactual analysis. Here we looked at what would have happened if molecular testing was following negative antigen results. And we would, if that was implemented, well, we would have seen a lower incidence of the escaping variant. We also tested what would have happened in Veneto if an Italy-like testing was used. And again, we would have seen a lower prevalence of that escaping variant. On the other hand, if only antigen testing was used, well, this variant would have thrived, right? It would have completely bypassed all the surveillance, and it would have really spread very happily in the population. And this is results from the counterfactual scenario. I didn't say I gave it for granted, but at the time, the policy was that molecular testing was following positive antigen testing. And so this is what we modeled. That was our baseline scenario. And this is about looking at what is the efficacy of really detecting sequences and detecting the true, like of having a view of what really is circulating in the population. And so here, you know, if we use antigen only testing strategies, well, we see if we only sequence antigen positive samples, well, we would completely miss discordant variants because of course they escape. If we were sequencing antigen negative samples, well, we would do a good job at picking up discordant variants, but we would kind of bias our ability to really pick up the proportion and the circulation of concordant variants. And I'm looking at the second column at the bottom. And so perhaps kind of a trade-off could be to sequence really 50% of the positive and 50% of the antigen negative tests. Of course, molecular testing provides an unbiased picture of the circulating variants. The issue is, well, from a practical perspective, it's expensive. It has some delays, and actually, you know, surveillance systems are doing it less and less. But I think the key take-home message from all this work is that really sequencing in a context where antigen testing is really dominating across the world, I think we shouldn't forget about sequencing antigen negative tests, because effectively these antigen escaping variants can pop up, and we've seen an example in Veneto. They can pop up in other parts of the world, and unless we sequence antigen testing negative samples, where we would really never be able to capture them. And so in conclusion, well, what have we seen? We found that SARS-CoV-2 had really spread silently in the population at the beginning of 2020. We gave one of the first evidence of there being asymptomatic infection in the population, and we gave one of the first quantitative estimates around 40%. We found Vo was one of the places that demonstrated worldwide that mass testing and lockdown, you know, were really successful at reducing transmission, and suppression was possible. We found that contact tracing, as it was done at the time, and I'm talking about traditional manual contact tracing, really had a limited impact on the epidemic. We found that most of the transmission is actually due to a small proportion of infections, and this is the over-dispersion in the offspring distribution. Antibodies decay, we know that very well now, but they do decay at different rates depending on the test that we use. Vaccination boosts the antibody levels, and so it does what it is supposed to do. Testing strategies based on molecular assays really are the only tools that allow to capture the true viral circulation, and sequencing antigen negative samples really needs to be taken into account if we want to kind of really detect potential antigen escaping variants. And I think this is my slide, my last slide. Thank you, and I'm happy to take questions.
Thank you, Ilaria, for the very interesting talk. Are there questions? I see there is one from Fabio Miller, please.
Thank you. I have two, but I will just ask one and then give opportunity to others. Thank you, Ilaria. Very nice and diverse in the type of work. Let me ask you about contact tracing. What parameters did you use in modeling? In other words, the reason that contact tracing cannot theoretically have a really, really high impact is that, as you pointed out, almost half of cases are asymptomatic, and you don't do contact tracing on those because you don't even know you should. And so that's an obvious parameter that is absolutely essential. But then in differential equation models, rates are absolutely essential too. And I'm wondering which ones and how many did you have in the model?
I think we took a very simplistic view, Fabio, here, and we really tried, we had a probability of being traced, essentially, and we calibrated this probability of being traced in order to reconstruct, you see what's shown in panel B and C, that's the traced contacts testing positive, and on the other hand, the PCR positive subjects, which were detected by contact tracing. So, and we assume that the life history of the disease among the traced contacts was exactly the same as in the rest of the population. So it was very much around trying to quantify what was the probability of being traced. And if we were traced, we made the assumption that we were completely isolated, you know, and were not contributed to onward transmission.
So thank you. If I understand correctly, then it's roughly 2 as parameters. This was a differential equation model, right?
Yeah. Yes, this is an differential equation model.
So basically, the probability of being traced is related to the rate at which actual contacts that you may or may not know about are detected and then tested. The other one that you mentioned then is the isolation, which of course is also essential. And so did you do some type of sensitivity analysis with respect to these parameters? I understand that for your purpose, you used the best estimate of what values they actually had.
Yeah, so I think in the baseline scenario, we assume 100% isolation, you know, but I can't remember off the top of my head, but I'm pretty sure that they asked about what happens if not everyone is compliant. And so we must have done some sensitivity analysis around, you know, not all of the people traced, isolating completely. But qualitatively, you know, the results were pretty much what I've shown you here. And yeah, essentially, really, contact tracing didn't add much to what contact tracing as was done at the time, you know, like digital contact tracing is a different story. It can be very effective. But what we've seen from this context is that contact tracing really had a limited effect, truly, on the dynamics. Happy to discuss the details if you want. This is published, but I can go through the equations if you want, and we can look for detail.
I'll take a look later. Thank you.
Okay, are there other questions? Otherwise, I have, well, at least one concerning the last point you discussed about testing negative tests that were negative, the antigen negative tests. Because in some sense, the idea is that molecular tests are more expensive and the health system wanted to limit their number. But if you test all the ones that are negative to the antigen test, then you would have to test a lot of them. And so you would lose a lot of these. So at the end, you said, well, perhaps you could test only 50% of those. I was wondering, I didn't quite get how you arrived at 50% or 30 or 70%. Or how
Andrea, that is completely arbitrary choice. Just choosing how much of the antigen, and it's very much an example. We didn't do a thorough analysis of whether 50 is better than 40 or 60, you know? And so that was just to give an example of really how much our ability to detect the true circulation of concordant and discordant variants varies with the testing strategy that we adopt. So that 50-50 was really an example. It doesn't come out from a thorough analysis, I must say. It was just intuitively one of the assumptions that we just wanted to show that the kind of testing that you do has an impact of what you see genomic on the sequences.
I see there is a question by Marina, so please.
Well, yes, actually, two questions. Now, the first one, of course, the study involved, was wonderful in a way because it tested more than 80% of the people involved. And then also the definition of symptomatic, asymptomatic was scientifically clear in a way. If I well remember, something like more than 37.5 degrees and cough or something like that. Now I wonder how much those parameters can be exported to the rest of Italy. And in particular, of course, the definition of symptomatic versus asymptomatic, it's difficult in a way because it depends on the threshold. So at least from other analyses, including ours, if you consider also the post-symptomatic, so the people who do not care in a way, they do not isolate themselves, then in a way the proportion of asymptomatic or post-symptomatic is actually higher than 42% or something, maybe 80%, 70, 80%. So okay, that's more a remark. So I mean that that study involved was a wonderful path breaking. Actually, I wouldn't systematically apply those parameters to the epidemiology of other regions or other. Okay, that's a remark. Now that the second question is about that story of antigen testing in Veneto. Do you think that there was also a behavioral response, that the fact that Veneto did a lot of antigen testing was in a way increasing the idea of people that you do not have to care, wear masks, etc.? Or do you think that it is just that problem they didn't do PCR testing unless you tested positive for so don't you think that there was also a behavioral behavioral response?
Okay, great questions. Okay, so in terms of the first remark, all the estimates that we got clearly depend on the definition that we used. If we were using different definitions, we would have got different estimates.
Yes, of course.
We can only be consistent with what we chose to be our definition. Yes. So that's fair enough, I think. But assuming that we are happy with the same definition, I see no problem with exporting and applying these estimates to other settings, because I think that, kind of that's an intrinsic biological property of the virus. It's not something that changes with contacts of people or social contact. So, okay. And then in terms of the second one, that's a good point. So that basically says, because there is so much antigen testing available, people may actually change behavior, and then maybe they can increase the number of contacts, right? We didn't test this. This is a good point. We assume that, well, we have variant-specific betas, kind of transmission rates. We do not assume that, well, effectively though, we are focusing our study only on the period where antigen testing were used. It is true that in this period, the number of antigen tests increases. So maybe you could assume that the contacts increase in time. I will be honest, we haven't included this as an option. Like, we haven't increased the contacts of the people as the number of antigen tests increases. Because it's actually, potentially it could be, It could be happening, but how do you really measure that? And I'm sure that if we do that, there are some identifiability issues from a very practical perspective.
Yeah, well, there's another point. Do you think that because of that antigen testing, the PCR testing in Veneto was in a way less effective than in other regions of Italy? Because
no, that's not the case, because PCR was used to confirm all of the antigen positive tests. That was a policy, and that was used throughout.
Yes, but do you? Well, you know, I'm from Lombardy. I'm not sure that that Lombardy was more careful than Veneto. And
well, I mean, the guidelines at the time were that for all antigen positive tests, they had to have a molecular test done to confirm the results of the antigen test. And this we have accounted for in our calculations.
Yes. I'm not sure that there was a really, let's say, a policy of mass testing with PCR in other regions. Meaning that Veneto was less careful in a way, because they were administering a lot of antigen tests, and they used PCR only for people testing positive with antigen. I'm not sure that the policy of other regions was more careful than Veneto. What do you think about that?
I understand now what you are saying.
I mean, because it very much depends on that different.
I mean, there are pros and cons, right? Because if you have lots of antigen tests, you are testing many more people, and they have the results in 15 minutes as opposed to in 2 days. And what do they do these 2 days? They're not staying at home, right?
But I mean, that is a very good point. I mean, a very, very, very good point.
Yeah. I don't know. I don't have an answer to this, to be honest.
Thank you.
Thank you. I see that there is another question by Fabio Milner. Maybe I will add a remark later about the policy in the province of Trento about that time, but I will leave for afterwards. So Fabio, please.
Thank you. Yeah, the second question I mentioned earlier, I think this is a good time to ask, which is concerning the cases that were not detected. So the discordant cases in the antigen testing, it was 1.5% of the total, 20 out of 1,300 and some. That's roughly 1.5%. So playing devil's advocate, I would say that you may be putting too much emphasis on something that's not worth a penny, in that 1.5% is an error you probably have in any numbers you are showing us. What's your reaction to that?
My reaction is that actually these numbers are actually quite important if you think that the policy was really, if the policy was testing sequence. So this was, okay, let me start again. So this was an independent study that was done in like a hospital-based study, independently established, just to try and assess, you know, whether antigen testing was worth and kind of, worth, you know, kind of using in a hospital setting as well, as much as in the population setting. And if you think, I mean, in a way, it is true that the numbers are small, but it's quite remarkable that actually we were lucky enough to find an antigen escaping variant in a way, right? It's, if you think that it's a quite rare event, well, here we go. We kind of found it. And actually, I think it is striking to see that in Veneto, this sort of antigen escaping variant had a higher prevalence than in the rest of Italy. And overall, I think, you know, all our estimates suggest that this variant had a very low R0. So it had no chance to really transmit in the population because there was another variant circulating at the time, which had a higher R0, and due to competition, it had outcompeted that. But had this discordant variant had a higher R0, it could have spread much more quickly, you know. It's so, I mean, I think there is a value in really pointing out that antigen escaping variants can happen, can emerge. And if we only rely on antigen testing, we are going to miss them completely.
Well, if I can add a comment from your numbers, I think the correct comment is that you had 61 cases that were positive to the molecular set, and of these, 19 were negative to the antigen set. So the probability that you get with the antigen test a positive conditional probability is
higher than 1.5.
It's not, we're talking about 30% that you're missing one. So I don't think it's, you can say it's certain. I see that there is a question in the chat by Pietro Monticone. I don't know whether you, Pietro, want to say that aloud or should I read? Ilaria, you can read it.
Yeah, I just, thank you. I didn't see that. So what do you believe to be the most promising approach to incorporate behavioral dynamics into population level and individual level epi models? And 2, what do you think to be the most appropriate methodology to try to decouple the spontaneous endogenous component driven by risk perceptions, expectations, etc., from the control exogenous component driven by policy interventions? Well, so I think that in order to include this sort of behavioral dynamics, all we need to have is data on behavioral dynamics. And unless we know how people change their behavior, you know, I think we could, you know, it's going to be difficult, I think, to try and include this information in the data. We, you know, the way we work is either we try to estimate the parameters, or we make assumptions, or we have data. So the ideal world is we have data on behavioral dynamics and how people's behavior changes, and we can incorporate that. We can try and, so my worry is if we want to try and estimate how people change their behavior, we are going to run into identifiability issues because essentially, so yeah, that's my worry. I mean, I don't want to say it cannot be done. That's something that we could potentially explore. That's the same, very similar question that Marino asked effectively. So what if people, you know, change their behavior, change their contact rates because there were more antigen tests available? Potentially one could try to estimate whether this has an effect, and potentially we could try and see whether the model fits better the data. I'm always very concerned about running into identifiability issues because then everything kind of loses significance. If we can't identify the parameters with some level of you know, kind of accuracy, then what's the point of doing this? Alternative is we can do scenario-based analysis and we make assumptions. And perhaps in the absence of information, that's a fair thing to do, which is like assume that X% of the population changes their behavior and they reduce or they, you know, increase the number of contacts, and we see what the effect of this assumption is on the model outcome. I don't know, this is how I would rationally include kind of behavioral dynamics. But honestly, the best thing would be to do surveys and to know if people have changed their behaviors at a social and population level, and to have some information about that. Because one of the limitations, I mean, this is not what I've told you, what I've talked through about today is not age structure models. But if you think about the last, you know, contact survey that was done in Europe, was done in 2008. And we are in 2022, and I'm pretty sure that contact patterns have changed, especially after the pandemic. So, you know, there are limitations in the data that we use. And so more data would be very valuable, I think, going forward, especially on behavior.
Okay, thanks a lot, Ilaria. I think we're already 10 minutes beyond 6, so I think we thank all the participants. We thank especially Ilaria for a very interesting talk. And I wish you all a happy summer, buona estate. I hope, e ci vediamo poi in autunno, speriamo al prossimo seminario. Saluti a tutti e grazie.
Buone vacanze.
Ciao, grazie. Ciao,
Ciao.
Ilaria.
Grazie,
Ciao,
Ilaria.
grazie a voi.
Ciao.
Ilaria.
Ciao a tutti.
Ciao, ciao.
Ciao, buone vacanze.
Ciao a tutti.